Good evening, everyone. Welcome to tonight's meeting of the HSCRG. Let's go through the admin first. Anyone in the room, if you want to speak, turn your microphone off. When you finish speaking, turn your microphone off. Anyone joining remotely, please turn your camera and microphone on when talking, and remember to turn both off when you've finished. Recording of this meeting will be available to the public within 24 hours of this meeting, and the meeting will be live streamed. Any in-person attendees, please switch off mobile phones or place it in silent mode. Okay, apologies for absence.
Yes, Chair. Apologies from Councillor Nasir and Councillor Fry, who's being substituted by Councillor Marshall, and from Stephanie Power from Health Watch.
Thank you. Minutes of the last meeting. But it's just the two of us who are there. They look okay to me, Claire? Yeah. Okay, thank you. Disclosures of interest?
None that I'm aware of, Chair.
Urgent business?
None, Chair.
References from committees and other bodies?
Again, none, Chair.
Okay. Chair's update, just a quick find this. Okay, so a couple of weeks ago, I had a meeting with the Director of Adult Social Services, a constructive meeting, one of the outcomes of which is that this group can expect a number of reports on social care in upcoming meetings, starting with tonight's report of the thematic review of safeguarding. I'm aware this group has concentrated more on the health aspects of our work, and hopefully we can redress the balance towards social care over the coming months. Okay, that's all. On to the first report. Luton Safeguarding Adults Board Annual Report. Alan?
Yes, thank you, Chair.
You.
Thank you. I think I've got colleagues Sam and and Jill in the room who may be coming to assist me with some of the detail. But I just wanted to start with a bit of an introduction, really, about the Care Act sort of sets out the need for each sort of area and Safeguarding Adult Board to publish an annual report, and that report should include, amongst other things, what the board has done, the findings from reviews, which I'll talk about a little bit later on, and how member agencies particularly work together. And it's really clear that in the safeguarding arena, it can only be effective if all agencies work collaboratively together, because it's a very complex space. The whole aim of the Safeguarding Adult Board is to help and support, safeguard and protect our most vulnerable adults with care and support needs. And we kind of do this by assuring ourselves that safeguarding arrangements are in place as identified in the Care Act, that we assure ourselves that safeguarding practice is really person-centred, that individuals give timely and proportionate responses when abuse or neglect has occurred, and that safeguarding practice is continually improving. And I'll talk a little bit about that later on. So you've got the report in front of you, and it's quite detailed. And I'm just going to concentrate on just a couple of issues just to sort of set the scene. Clearly, there's my colleagues from Adult Social Care who may wish to intervene at that point. But I guess my role is as independent chair is set out in the Care Act, and it is to sort of give support, advice and leadership within that safeguarding arrangement, to also to offer constructive challenge and to hold agencies to account, and to act as a spokesperson for the Safeguarding Adult Board, which I guess is why I'm here today. So the report that's in front of you today covers 2021-22. So you may say it's a bit out of date, and it is, but I think the reporting schedule and processes and coming to various meetings sometimes mean there is a bit of a delay. We're about to publish the newest report, which is in being at the moment. So once we've done that, that will be up to date. But a lot of the key issues in this report reflect the ongoing work today as well. I think it's fair to say that safeguarding remains incredibly challenging. It was during that reporting period and continues to be so now. And a lot of that was due to the pandemic over this period of reporting. And the partnership, I have to say, worked really well together to support vulnerable people who are at risk of harm and abuse. And obviously COVID pandemic and its restricted lockdowns and all the other paraphernalia that went with that caused additional complexities for the partnership. And I have to say they work really well together to find ways through that, to seek out and identify our most vulnerable people and give them the required support. A clear priority for the board has been over this past year and continues to be making safeguarding personal. I think we're delivering on that. We've had a number of reviews that have highlighted that we haven't been as effective in that area as we could have been. And so we are now making progress on that, and we're delivering using the 6 principles as advocated in safeguarding, those of empowerment, protection, prevention, partnership, proportionality and accountability. They are the key 6 strands that run through everything that the SAB does. I think in general terms, it's really been challenging for health and social care. There's been significant pressures on both the health service and the social care system, with significant increases in demand. We've seen an ever increasing volume and complexity of safeguarding issues as well, and concerns with individuals who experience a wide range of multiple disadvantages. So, you know, over this past year and ongoing now, we're seeing a number of individuals in Luton who are suffering problems with homelessness, domestic abuse, substance misuse, mental health, alcohol abuse, contact with the criminal justice system and sex work, you know, to name quite a few things. So there's been lots of complexity and lots of challenges for the workforce to grapple with in trying to safeguard our most vulnerable people. And those issues that I've mentioned there have been further analysed in some of the Commission's safeguarding adult reviews. I just want to talk a little bit about the safeguarding adult reviews, because that does take up a lot of time in the safeguarding adult board and a lot of effort of agencies to deliver on those. So the purpose of a safeguarding adult review is to undertake, obviously, a review when an adult has died or has been seriously harmed as a result of abuse or neglect, and there have been concerns about the way agencies have worked together to safeguard that particular adult. And the purpose of any SAR is to identify system improvements to prevent deaths or serious harm occurring again. What a SAR is not about finding out who was culpable or apportioning any form of blame. There are other processes for that, but it's certainly around identifying improvements in our safeguarding system to prevent a recurrence of similar themes. So these reviews inform effective learning, and there is a real need for us to learn from them. And I think one of my challenges back to the partnership is that, you know, we're seeing similar themes come in from safeguarding adult reviews, and that you know, we need to ensure that we are learning from these reviews, that the actions from the recommendations are embedded into frontline practice, and that we do see improved outcomes for our most vulnerable people. There is detail in the report of a number of the reviews that we have undertaken, which may be there for you to view in due course. But I do want to make sure there's time for questions. But in a nutshell, what I would say is I've certainly found in Luton that there is a really effective collaborative partnership. Of course, there are complexities and things that we need to improve. We certainly need to learn from our safeguarding adult reviews. We need to improve timeliness of our Section 42 assessments. We've found that through auditing. So whilst there's a lot that we still want to continually improve, but I would say, you know, there's a very collaborative partnership that health, that police, that adult social care, you know, that other partners work very, very well together to ensure that we're delivering a safe and effective service for our most vulnerable adults. So I think I'll stop there, Chair, if that's okay, and perhaps have time for some questions, unless there's anything you want me to expand on.
Thank you, Alan. Not at the moment, I don't think. Does anyone have any questions? Okay. I've got a few questions. You're talking about the collaborative process, like the interagency working.
Yeah.
So if you dive down into the thematic report and the action plan that's linked into the report, it does several points in that report. It talks about tensions between different agencies and differences of approach, and for example, when the safeguarding process is triggered, is that a serious problem? That sort of dispute or tensions between the different bodies on the board?
I mean, we do obviously encourage sort of challenge and scrutiny within that board process. So, you know, it is really important, and I want to say, you know, if there are tensions, that they need to be aired. I do think part of an effective and mature relationship is that we can have those difficult conversations, if you like, in a board setting, so that some of those things can be addressed. I'd much rather it that way, and that we can highlight that we are identifying areas where we do need to improve our cross-agency collaboration. And certainly, you know, there are agencies outside of, you know, the local authority. So, you know, within health, we know that there's been some tensions between various health departments and other agencies. So you know, but having a board process, I think, does enable that to be challenged and enables that to happen. So would I say it's a serious problem? No, I wouldn't, because I think we're able to recognise them, and agencies can have those discussions, and if need be, take them at a higher level to get them resolved, which is a part and parcel of the role of the Safeguarding Adult Board. But I don't know if Sam or Jill is there that want to add anything further to that from their engagement with the process on the ground.
No, I'd pretty much say Sam Parker, Head of Safeguarding, Quality and Professional Standards Adult Social Care. I'd echo what Alan said. I mean, you do get differences, but even at the operational level, certainly at the front door of safeguarding, I think actually it's quite a collaborative approach in Luton. There's always things to be smoothed out, and you know, that's some of the learning that we've seen from the SARS. So yes, sometimes professional disagreements are there, but I think, and I think my safeguarding colleagues from across the system would echo that. The feedback we get is Luton's quite collaborative, and we do feel that we can air those differences. And sometimes it's about learning as well. I mean, one of the points might be, you know, it's really important to get safeguarding awareness out there, and I'm thinking about the third sector and out to actual, you know, families as well, because obviously anybody can make a safeguarding referral. But what somebody might perceive as safeguarding might not actually be safeguarding under the law, and it might be that somebody needs some care and support, but it wouldn't be safeguarding. And so sometimes you get in lots and lots of referrals, and obviously that can put the system at risk because we're actually looking for the safeguarding. So some of that's, it's not a tension, it's just about making sure we continue to get that collaborative learning out there to the wider partnership. And I think that's something that the board is well placed to be doing, because, you know, adult social care is a big part of that, but this is about the system, it's not just about adult social care. So, you know, that would be my addition to that.
Okay, thank you. So coming into something a bit more specific. So recently, the policing minister stated that he wanted to reduce the number of 999 calls that were safeguarding issues. He wants to reduce the number of those that are being dealt with by the police and reduce the amount of time that the police had to deal with those. Is that going to, what sort of effect will that policy have on safeguarding?
Am I right, Jay? You're thinking about particularly the right person, right care approach, that in relation to mental health particularly? Would that be what you're referring to? Because I think that there is obviously, yes, I mean, the police have said over many years now that they are spending a lot of time dealing with mental health cases where there is no risks to life. So in effect, they call it babysitting until they can get the correct professional there. They are now saying, and it's, you know, in progress, and they're articulating it quite well, that is going to come into being in September, I believe. There are potential risks to that, and I think we as a board need to understand those risks. We've asked the police to come and tell us what that means from their perspective, but also that will mean that there is a responsibility on mental health agencies and services to ensure that they pick up that gap, because the last thing I would want, or any of us want to see, is somebody who is vulnerable with a mental health issue, that there is contact made to services that nobody can attend, and sadly something terrible happens to that individual. So for me, my role, I think, is as chair, is to assure ourselves that whilst I understand the reason for them saying what they're saying, but as a system, we need to make sure that our most vulnerable are still being protected. I was thinking about it only the other day. I think I need to have that discussion at board. We need to perhaps monitor that as a potential risk in our safeguarding system, and ensure that we mitigate that risk as best we can. So we want assurances from mental health professionals that they are going to be in a position to pick up those calls, which, you know, the police are saying that they're taking on, but they haven't got the capacity to do so, and it's not their role to do so. So I think, you know, yes, we're aware of it, and yes, yeah, we will have those further discussions, Chair.
Okay, thank you. Does anyone else have any further questions or want to add anything? Okay. Sorry, Jill. Yes.
That's all right. I just wanted to add, just to say that that was a meeting with a large number of the senior executive staff from the East London Foundation Trust, who delivers our mental health services, and we were talking just about this and about how we're kind of working, how they're working with the police to understand what the impact of that will be if it's enacted, and similarly particularly for our out of hours services, for our approved mental health professionals who sometimes need to access people's homes against their will for their own safety. So there are issues where I think the police will be needed. They are the only professionals who can do that, and so it's just making sure, I think, that as we've worked with the police and other agencies to make sure that we're not sending unnecessary safeguardings, that we're similarly not calling the police when it's not unnecessary, but that all partners are working together to ensure the safety and collaborating where we do need them, because we do have our own specific roles and duties and responsibilities to make sure that's all joined up. So that work is underway. But yeah, you're right, there is a risk that could be an impact. So that's why we're working really hard to try and avoid that.
Okay, thank you. If that's all, thank you very much, Alan.
Thank you, Chair. Thank you.
Thank you. Okay, next item is primary care access in Luton. Vicky.
Chair. Hopefully everyone's had a chance to look at the papers. And I was just going to really pick up a couple of points. Is that ongoing work with our residents. In fact, it was in last month we were invited to Health Watch's AGM and their 10th anniversary. So Monjour Ahmed is our clinical lead, and he presented, and I think that's quite useful. It's really about understanding what the availability is of primary care. The 3 points really, it's very much our focus is supporting prevention and self-care, and that really is helping communities and residents work together, because we have identified that, and this is not just Luton, this is nationally, there's a lot of people coming for accessing primary care where, you know, if you were living with families or parents, you'd probably ask those questions. So lower acuity stuff. So that's quite important. And equally the prevention bit, I know we picked up previously in this about the musculoskeletal procuring. It's about inactivity. So inactivity is not good for us. And equally about supporting healthy eating habits, because being overweight can cause a lot of issues. So the prevention and self-care is a big area. I think the other part to focus in on is about supporting residents to understand the best services. Sorry, that's bringing it. So that's a point that Amanda, who wrote the paper, has entered. I think over the last 3 months, so it's still about 308,000 appointments, and increasingly about the skill mix. So although this time the numbers, the percentage, it's this month, the last 3 months is about 53% of GPs, 47% others, and still a high number of face-to-face. So again, the reason we share this report is very much on that sort of sometimes myth busting that there's no appointments. You have to be careful when you're looking at statistics. You'll see that the percentage of same day has slightly reduced. So again, being optimistic, it means that pre-bookable, i.e. that I've got a routine appointment I might want to have in a week's time or 2 weeks' time, not literally I want it today. So that percentage has decreased of same day. And I think hopefully the slides are showing that it is that whole system redesign, and it gives you that diagram on the page of sort of traditional versus allowing people to come into walk into general practice, because that was a myth that people weren't allowing it. So of course, general practices do quite like people doing online, and they like people using the telephone. But if there are residents that prefer to come in, that's quite acceptable. And we're doing a lot of work, or the practice is doing a lot of work on what we call care navigating. So really the old style of a GP receptionist is really gone. It's about they're trained up to help navigate. So it may be that you can see another member of the team, maybe a community pharmacist, it may be a paramedic, maybe a specialist nurse. But if you see somebody else, it's because it's clinically appropriate. So I'm going to pause there because it's really about answering questions, and I know some may want some questions about Wenlock.
Okay, thanks, Nikki. Okay, does anyone have any questions?
Yes, please, Chair.
Councillor, please.
Hi, thank you. How do you monitor, because after since COVID, still lots of GP practice, they advise people to make a phone call, make an appointment. They don't open the door to, there was no walking service for booked patient. Then also some elderly people, they're not, they are not good at telephone, and people are waiting. Then by the time they reach, everything got booked. So lots of people are frustrating about the, booking systems. So how do you monitor like all the GP practice? You practicing the same things like before COVID, like walking, like anybody walking to the patient, like the GP service and booked. And also from my experience, my local GP, they don't have any pre-booked. They have same day appointment, which is then thing ICB look into for, people may not need immediate booking, but they need for, follow up things. When I talk to the GP, I asked when I had a personal conversation with GP, they say this is the GP, they made a rule because sometimes patient pre-booked, they don't turn up, so they lost the time. So which is makes from them it makes sense, but from as a working people from us, like they want us to call to like 9:15, which is busy time for school drop and going to work, So is there anything ICB can look to improve booking appointment?
So I'll try and address those. So about how we monitor. So increasingly how we're monitoring is how I've showed in the paper is the totality of appointments. Now, part of the work that we're doing, and that's at a national level, but within Luton, to get all of the practice onto something what we call cloud-based telephony. So there's then a facility for if you telephone, you'll know where you are in the call, in the queue per se. So once all of the practices have that, we can do that benchmarking, and we can actually monitor how quickly telephone calls get answered, etc. So was your question about some practices not allowing you to walk in to make an appointment?
Yes, like yes, to book appointment. They want they ask to make a phone call in the morning And wait.
Okay, so again, I think, and that's where I said, is that practices can encourage people to say they want you to book online or to go onto the telephone. But if anybody finds any practice not allowing somebody to walk in to make an appointment, that you need to tell me, because they all know that's not acceptable. It could be people have hearing problems, they could have language problems, they could have all sorts. So if I pick that up, we've got very good clinical leaders, and we will help people to see the error of their ways. So
No, because like what they said is people need to call in the morning for appointment, and all are same day appointment, no pre-booked. Even if they're allowed to come in, they say, oh, everything got booked because you have to call like 8:45.
So again, I can pick up on an individual basis, but this is the whole point about not 8 o'clock rush. So, and that's what on that slide that we're all working with. So Mondra Ahmed happens to be our strategic lead for access across Bedfordshire, Luton, Milton Keynes, but it's also in addition got some sessions to support the practices in Luton to prevent that. So you shouldn't, so what we absolutely, and there's a target date and it says in the paper, but what we're encouraging practices to do is, if I phone, is that I know what I'm not just asked to ring the next day, because that's totally and utterly unacceptable, and that's been led at a national level. Now we're working through that, and again, needs to be clinically led, because ultimately the practices are managed by the lead partners of a GP. So again, we'll pick it up on a case by case basis, because it needs to be, it has to be a service that's acceptable to residents, and we are making it very clear contractually what's accepted and what isn't.
Councillor Marshall, then Councillor Isles, then Councillor Allen.
Thank you. I don't normally sit on this group, so if my question is naive, I apologise. I'm just really interested in terms of the number of GPs that we have in relation to the population. We hear all the time on national press and national news there is a massive shortfall across the whole country in terms of GP numbers. So how do we stack up with that? Is there a target with GP practices to recruit individually, or is there a sort of overall plan to increase the GP numbers within Luton? Thank you.
So certainly not a naive question by any manner of means. So within the contracts themselves, you need one GP has to be a signature on the contract. So it's not it wouldn't be a statutory, I wouldn't be able to have a contract with them without one. So increasingly, it's a really, really helpful question, because you could argue that if you've got a very well-trained paramedic and the needs of your patients are more same day and are more attuned to that practitioner, you'll be better to have more of, to have different clinicians of different skill sets. And interestingly, that all of the practices we have initiatives all the time, but the latest initiative that came out in May of this year is profiling what the patients. So increasingly, we know in Luton there's a lot of little children and a lot of young families that have a lot of issues. So paediatric nurses we haven't been, tended to have working in general practice, they would be ideal. Equally, you can have some pharmacists who've specialised in children, young people.
Sorry, Vicky, can I interrupt? Can you move one chair along, please? Because we're getting some interference on that, feedback on that. Otherwise, yes, thank you.
I'll go with that one. Is that better? Yeah, perfect. So it's about profiling patient need to clinicians. There was, I don't want to get political in this, so there was some numbers for how many GPs were supposed to be recruited. They've moved now to what they call additional staff, and it's this magic figure of 26,000. We're not doing too badly. We've got a pretty good primary care training team. We call it the training hub. Our GP numbers are slightly better in Luton than, for example, Central Bedfordshire. So there are some areas. However, I caveat that we have practices with some higher deprivation. So you could argue you need proportionally more, and you may well need some more of those GPs that may be better serving those patients. So it is a bit of an art and a science, but we do monitor that. And if you want them, we can, in fact, anyone, they're available on the websites. I try and explain where we're talking about additional capacity and capability in general practice. And it was through the development of primary care networks that came in about 5 years ago. And each of these networks are groups of practices, and they get an allocated budget where they can spend it on a whole range of professionals. Last year, for the first time, they brought in some non-clinical role, which I have to say has been very valued, and Luton have taken advantage of it. It's what we call sort of information analyst, because if you start really using your information and you've got that skill set, you can often save a lot of clinicians' time. So, but Luton's not doing too badly. I think partly we had a bit of legacy, is that the previous chair in an iteration was very interested in sort of education development. So we had some quite innovative GP selection schemes that linked with Bedfordshire University. So that's probably why we're in a slightly better position.
Hi, I just wanted to find out about, the models that you have here, the traditional model and the modern general practice access model. Obviously, traditionally, you have the receptionists as the gatekeepers, okay? And I think you mentioned that it's going to be changed and there's going to be training. I just want to know, how long, have you got a rough idea how long the training is going to take, and how the practices are going to monitor the ones that are doing this frontline contact at all, please? Thank you.
Yeah, so it was a new initiative. It was what we call Recovering Access to General Practice. And there's a big emphasis on front of desk. So that's why we're trying to get away from this idea of GP receptionist. Sometimes they're caricatured as quite, a blockage to people accessing the services. And equally, some patients have been quite reluctant to share information, thinking that, that confidentiality. So the focus of attention has been on those frontline staff, and there has been some national training that's been available, webinar training, and we have in addition been supplementing that with some localized work, particularly looking at patient groups where you want to have something with some special attention. So for example, we did across Bedfordshire, Luton, Milton Keynes, people who are deaf. And actually, how do you address those sorts of things? So some characteristics where you just need to think out of the box in the sense of with staff. So those practices, we're monitoring the ones that have less what I would call favourable outcomes of patient reported measures. So reception staff, then we really do suggest to those practices. And in fairness, it's a partnership with them. They welcome that, and it's not cost them anything per se. Admittedly, they've got to spend, the workforce time has to be identified. But equally, I think the most important thing is that the practices in Luton have worked quite well together through those primary care networks. So again, we're very welcome to share which practices are doing it in which order. That's all part of this plan that we're putting together.
Can I just, if you could share it so that we can see,
of course,
just a breakdown, a table of who started and how and where they are in the training as well, and then what's to almost like a gap.
Absolutely.
Yeah, if you could.
Because the other thing that we've said increasingly is where practice is doing well, it's really, really helpful to have some of that positive feedback. And Monju Ahmed, the GP I mentioned leading this, has very much done webinars and facilitating practices to help other practices that may not be doing quite so well. It's to try and get that shared learning, because we want all 220,000 population having a good experience. There's no point in half the practices having a good experience and not the other. So yeah, 100%, again, really helpful. Within the team, and I know Sally Cartwright's away today, but with the public health teams, we're really doing some homing in, focusing on to residents, and particularly what we call some seldom heard groups. What is it they need? Because it isn't always about people come forward making complaints, etc. It's those people that don't come forward at all. So some of those measures we're looking at is things like vaccination rates, screening rates if people aren't coming forward, trying to understand it's accessing the service as well as people's perception of getting through to the telephone, which is clearly frustrating.
Thank you.
Hello, I think I've spent at least an extra full-time job talking about primary care over the last 2 weeks with the closure of Wenlock Street Surgery. I don't want to bore everyone by asking millions of questions because Nikki and I and James have had lots of chats about what's going on, but these numbers look like they're improving in comparison with England's position and that sort of thing. But we do have the issue that 3,500 people have been disseminated to other surgeries around Luton. And realistically, they will impact the numbers. We've not magicked up a new GP from elsewhere. Basically, what are we doing about this sort of a bit more long term? I know it's not set in stone yet and there's lots of things going on, but I have to bring this up for our residents because it's not actually only going to affect Hightown residents, it's going to affect those in the other areas where they've been sent to another GP surgery. So that was my first question. I have millions more, but I guess this is not the platform to talk about this. And my other question was, so some GP surgeries, I don't know if they do so in Luton, but they have sort of online consultations or the ability to send messages to GPs, say, I've noticed that I'm doing this a lot, and then the GP will reply saying, oh, why don't we book you in for a blood test? You don't have to see me yet, let's do this. How are we adopting this in Luton? Is anyone already doing it? Is it something that we could look into? Because it seems quite efficient when I speak to friends from other cities and towns where they say that they use this. So yeah, thank you.
So if I start with the last one, so basically there's 3 ways in: using the telephone or what we call online consultations, and there's the software for that, and obviously being able to walk in. So the online consultations are available to all of the practices. Interestingly, Wenlock were the one that didn't use it for online. I'm just thinking it may be that, and I can try and arrange it. So Mondra Ahmed, the GP, is far better because it's his day job, and he will talk about, what the online consultation is and it isn't. But all of them will provide that. So just being quite clear, an online consultation. Has anyone used it actually? Has anyone had a chance at using the online? So there is, on the practices, there is something called an online consultation. Most practices do turn it off after closing time, and that is something that's been debated at a national level. And I'm not saying Luton at all, but what was happening is that often people at night time were writing messages and by the morning they resolved them. So in the end, and that's a very simplified national version. So practices have, and with all the various statutory unions, etc., have agreed that it can be turned on and turned off, as in, so otherwise they got into work and they've never moved off the first base trying to deal with all these online consultations. So again, we can talk you through one of those because that's quite a useful way in. But as Monjur will say to you, is that is just sometimes a way of triaging. So the clinician will look at it and they will say to their care navigator, can you bring this person in for an appointment? So it's, again, how the practices use it. And again, Monjur would say is that part of his work is helping practices to modernise, because I'm quoting him, is that we've got a spectrum of some that have used technology and worked in that sort of modern way, and some people are still working slightly in the more traditional way.
So I know you're saying that they can turn it off after hours, but do you know if any GP surgeries are actually utilising it here? Because I know my surgery don't. I haven't had the chance. I've not actually heard of any other.
Barton Hills Medical Group, yeah, you can contact them online. I'm a carer for my brother. I say my brother, I don't know, needs a blood test or something, and they'll message me back with an appointment and stuff. Don't have no contact till I actually get in there or whatever. Yeah.
So yeah. I've just not seen it in my practice, and I always thought this would be convenient. So I'm just not, maybe perhaps not all of them are utilising it, or it's available and it's off.
And they may not, and that's why I say so.
Okay.
All of them have the facility.
Okay.
So we've set up. There is the software for them to do that. Yeah. I can do a bit of that with. So, and then in the other question, and just in for openness. So, Wenlock surgery closed on Friday. So there were 3,300 patients that were reassigned to practices in Luton. There were 7 practices. And there were, I mean, it was quite quick, if I'm really honest with you, is that the resignation came in and we've had to work with some speed. So yes, you are quite right, there is that workforce reduced. I know that the staff, again, they're private matters, they're private businesses, but we have facilitated any staff that wanted to move, and that's other practices working in that way. And in fairness, that is a whole point of profiling our workforce. So we do know we have got quite a lot of older people that are near to retirement age. And that again is what the workforce profile. And again, in Luton, we've probably got percentage-wise, we have more practices engaging in training and development of the workforce. So each of the primary care networks, and we've got 6 in Luton. I have to double check. I think it's 4 out of the 6. It may be 5 out of the 6. It's definitely 4 out of the 6 have engaged in that training primary care network. Exactly that, to take on and to make sure all the evidence is if you learn somewhere, you're more likely to stay somewhere. So that's a really positive. And we've got a number of GP practices that are qualified trainers. So, yeah, you're absolutely right. I think the only other point I'd raise is that the resource that was at Wenlock will move to those practices. So there is the opportunity for the primary care networks to, recruit, et cetera, et cetera. So it's certainly not a cost-saving exercise in any way.
That was mainly my question. I know we were talking about resources, but spreading one GP out into 7, that sort of thing, basically additional staff and how we're going to approach it in the short term, rather than, of course, I know we're training for the long term, getting locums in or whatever is needed to reassure people that they're not going to be waiting even longer because of this, what's happened.
Hey, thank you. Just to follow up on that, how is you're talking about the transfer of staff from Wenlock to other, how is that going? Are the other surgeries coping with the increased demand?
I have to say it's a very small surgery, and where staff had wanted to, they've been supported. But again, because it was a resignation of a contract, the arrangements are slightly different. So the Integrated Care Board are not at liberty. It's not as if staff would stupid what we call transfer over, but again, we'd be rather stupid not to facilitate and support staff who wanted to continue. And that's not me, that's the local practices in Luton that have actually opened up their arms and said, look, if people are wanting work, and equally the federation that we've got in Luton. So there has been that facility if people wanted it.
Okay, got a general question about support for the primary care networks. You're talking about telephony systems and IT. What sort of support are you able to give the primary care networks and the GP practices in implementing the new technologies?
So at the moment, the Integrated Care Board, we have teams of staff. So we have the primary care team that I lead. And in addition, we have the chief nurse, Sarah Stanley, her team. There's staff members that very much support practices about to have a CQC visit. And I know you did safeguarding before. There's training for safeguarding adults and children. There's support for a whole range of things, infection control training. So we try and wrap round. The biggest thing we do is try and facilitate the practices to work together, because that's the whole nature of primary care networks. There is every bit of evidence across the country that you can keep small and nurtured but you do need to have some resilience, and that's why that networking comes into play. Within the access report, they'll talk about the primary care networks providing advanced access, and that is, again, Monjur has said, I think he said at the AGM, people don't make as much advantage of it. So that's in evening appointments, there's still capacity. And again, it is about looking at the GP practice websites, but equally people asking into general practice themselves. So the more we can get the practice to work in a collaborative way, and I do also emphasise that primary care includes 111 services, so that we have there is a primary care offer 24/7. And I've been quoted many times that ideally ring your GP practice if you know who it is, but if you really don't know, you can ring the 111 and then we can guide and direct you. There is the facility of direct bookable appointments from 111 into the practices. In addition, there are occasionally some stoical people that will ring 111 and really is a 999. So that's the 111 service has that ability to call an ambulance and redirect the call with immediacy. So there's a lot of work taking place with the 111 providers. So, for example, with the industrial action that's been taking place, we have bought more capacity from the 111 providers. So front end of it is telephony, and then behind the 111 is something called the clinical assessment service, which is a whole range of professionals, including GPs. And our model that we have in the Luton and Bedfordshire system is quite GP heavy, in the sense that that's the model, tends to be most senior person, and then it may be that you see a pharmacist or a mental health practitioner. But as far as that service goes, it's fairly robust, and it compares quite well with other services if you compare them regionally and nationally.
Okay, thank you. So anyone else? Any more questions? Just got one more, Nikki. It's in the press recently, I forget who it was raising concerns about the upcoming winter and the ability of the NHS to cope with a flu epidemic. Are we prepared?
We're certainly in the process of preparing. And in fact, Jill and myself are having a meeting on Thursday on that very basis. And again, a very helpful point, because one of the aspects of that plan is how do we support our residents that we know locally. So how do we work with the community voluntary sector? And often it's about recognising if people are getting cold, if people aren't eating. I go back to sort of community kindness, but there's don't underestimate those sort of interventions for winter preparedness. We're having a discussion, I think, at the Luton Place Board, and my understanding is that probably the warm places will continue. So what I think the very first thing is to demedicalise some of that winter pressures, but we're likely to have ongoing industrial action. So we are working with our 111 providers to make sure that we can buy that additional capacity. And I think it is about there's some work with regards to secondary care, working closely with primary care. So if somebody has been in hospital and they've had some tests or they need certificates for work, that the secondary care clinicians complete that and don't pass the work onto primary care, that then clogs up the system. Now, we last year very successfully had some what we called acute respiratory infection hubs, and that was led by the primary care, by local practices working together, primarily people who were presenting with respiratory conditions and wanted something fast. We had additional funding for that last year. So we have, as an ICB, pushed again back up to the national levels, is that it's not easy to suddenly create a whole load of capacity if you don't have some funding. So general practice are working jolly hard, as you can see, with those 308,000 appointments every 3 months. So in answer to your question, we're preparing for it, and it needs that whole system. So really working very much with Jill. I can see Michelle over there. It's all providers working together, but primary care are a big part of that.
Okay, thank you. Thanks very much, Nikki. I think you're on for the next item.
And I think it's just to check how people would like to work with this. So because we recognised there were new councillors, the pack was there to do a bit of an induction. And I know some of you may have been party to it. So I'm happy to go through the slides. I'm happy to answer it however you think best, Chair.
You asked one of the people who's already been through the presentation. Would it be useful for you to go through the slides?
Shall I try and work out just some of the I'll just say where the decision making happens, because I think that tends to be the area where people think, well, all these discussions take place and what, where does any action take and where is it making any difference to the residents? So if I pick up on that bit, may be helpful. And also if I just emphasise that, so Rima Makaram is the chair. And Felicity Cox is the chief executive, and there are a number of executive colleagues. So I'm the chief of primary care, and I'm also the link director for Luton. So because we are really passionate that everything, and I say everything, that decision making should be as close to the residents as possible, we're really passionate about making sure that the places, so obviously here Luton, Bedford Borough, Central Bedfordshire, Milton Keynes, it starts with place, and actually it's how the system can help the place rather than the place leaning into the system, if that makes sense. So we have my colleague Sarah Stanley is the link director to Bedford Borough, Anne Briley is the link director for Central Bedfordshire, and Maria Wogan for Milton Keynes. And that doesn't mean that you don't have the full array of the execs, it just means you've got a single point of contact if there's issues. So if I start with the integrated care partnership, where councillors and the leader of the council are part of, and what's really important is it's about the new integrated care board is the engine room for the system. So the partnership, the integrated care partnership, is where the strategy is developed, and that strategy was developed and signed off last year. And then it is up to the primary, so the integrated care board, to then do the delivery of that strategy. So just to give you a feel, so all 4 local authority chief execs sit on the integrated care board. That is decision. My understanding is BLMK has one of the largest integrated care boards. We have 3 members with a perspective of primary care. We have 2 GPs and 1 community pharmacist. And again, I think it's worth, the GP happens to be from Luton and the pharmacist happens to be from Luton, but it's giving a perspective of their area. It's not a representative board. And I think that's really important. If I emphasise slide 4, which is the slide that says what contributes to a person's health, we use that a lot because you'll see that 20% of somebody's well-being of health is down to healthcare. That's not to that's not to belittle it, and of course that 20% needs to be good, but the most important thing is that socioeconomic factors, the physical environment, and the health behaviours. So as an example, last Friday, the Friday before, the 21st, we had, as part of that integrated care partnership, a real focus on employment, because we know that employment of working age people will probably have a better outcome to their health than many others. So in particular, we looked at people with learning disabilities, people with mental health needs, people with long-term conditions, and you suddenly see the real discrepancies in those communities. So we had some real fantastic in that day, some lived experiences, and for example, somebody who had a chronic inflammatory long-term condition that it meant that she was unable to work for some weeks. and how do we all work as anchor institutions to support those people who have got great opportunity to provide, good, they're good workers, but you just have to be mindful and sensitive to people's health needs. So it's about having a different conversation, and that's the sort of area that we really feel passionately in the Integrated Care Board. It's about how do we add good years of living to people's lives. So the slide talks about those partnerships. Again, the priorities, and we're in Luton, and you would hope that they would marry, and they certainly do, is the start well, which clearly very important with Luton, with the young population, live well, age well. And again, it is that economic growth and reducing inequalities. So the 2040 vision is absolutely 100% respected, and it's about what can the ICB do to support Luton in that way of working. The slide 9 about how the system works, hopefully I've just given you a bit of an idea. So on the right side where I said about the partnerships, about setting the strategy, and I mentioned the Integrated Care Board, it's about the engine room. I think the other important thing, and I certainly know that Michelle and Jill are on the place boards, it's about how we make a difference at place. So we are actually looking at winter preparedness at the place board next week as an illustration. So it's again how we work in that way. Now, clearly, primary care. If you ask anybody, and we've done the big conversation, primary care and increasingly access to dental are the two big things that come up, time and time again. And again, it's about recognising. And I think Monjur, the strategic clinical lead for access, will describe that you almost become a victim of your own success, because 90% of all traffic goes through primary care every day. And we have today, we would have had about 29,000 appointments across BLMK just in one day. So, I mean, it is, and again, the reason we quote some of those numbers is about just myth busting, is that people are working hard. But we need to work in modern, effective ways, and clearly increasing that workforce. And then we do have some challenges on estates as well, and we're all fully aware of that. I think the cover sheet said that the ICB came into operation in July 23. It was the year before, so it was July 22 the ICB was established. But in April of this year, the ICB took accountability of commissioning pharmacy, optometry and dentistry. And we all know at a national level that access to dentistry is as hot a potato as it is to primary care. But again, in Luton, we've got some, through the thanks actually of the public health teams, are doing some really good proactive, particularly with young people, some prevention work in dentistry. But again, that's working together. Digital transformation we've highlighted, and again, funny enough, in the place board on next Tuesday, we're having an update on the Wizan monitoring boxes and the razor chairs and the acoustics, and that's basically using some what I call Wizzy technology to try and help workforce. For example, the razor chairs are quite a novel. It's a humane way of actually helping to get people off the floor, where previously you might have waited hours for an ambulance because it may have been seen as a low priority call, and now you can use that bit of technology and get the person back up and comfortable, and it just takes all that panic away. And again, in Luton, we've worked in that collaborative way with the Better Care Fund, so there's always been quite a bit of use working together on that level. Social prescribing, again, that probably happened in Luton before other areas. And again, with the Luton Place Board, we're just making sure we've got a resilient model, because it's probably one of the biggest successes actually. In primary care, there is social prescribing that very, very much supports people who need guidance, support, and that ongoing. So social prescribing works really well, but we just need to make sure that it's a resilient model, and more to the point is that people continue to work and like working in Luton and have an infrastructure to support their career development, etc. The NHS low calorie diet programme has been a monumental success at literally turning people's diabetes off, where they were, early onset diabetes is by weight reduction. They're off all of the treatments, and if you did, blood tests, you wouldn't know they were diabetic. So that has been some real success, and that's down to the team. The leadership there is another Luton GP, a Dr. Chirag Bakai. So he's done some astonishing work, and also some of the preventing diabetes work. From identifying people higher risk, helping children living with epilepsy, again, a very joint effort with children, young people in LBC and the L&D, Luton and Dunstable, where children with complex epileptic problems, they've used some again, it's some whizzy technology. It's something called Patient Knows Best, and it's whereby usually the parents, but as the children get older, they can use it, where they can map down symptoms, and it's just a way of shared management with clinicians and carers. Targeted lung health checks, again, that was really homing in on high risk people of a certain age who were previous smokers, not waiting for them to have symptoms to do some proactive identifying of lung cancer. And we put in those slides the highly commended, and that again, that's some collaborative working, very much led by the public health team, how we're addressing inequalities. So it gives you a breadth and depth, and I hope it just emphasises that it's how we work together. It's not the NHS working in some silo. It's again, we could probably do more and more and more, and it's also for me about the connectivity. And that's why we said working with local councillors is probably one of the keys, because often we don't know what we don't know unless we work with the communities.
Thank you, Nikki. Does anyone have any questions? Okay, it's one of the things that's really emphasised with the ICB is the what's the word? Working at place, working at a local level. I know that in discussions about this, when it was being set up, a lot of members had concerns about whether the interests, health interests of Luton residents would be somehow subsumed or swallowed up by the requirements of a board, which, as you say, is one of the biggest in the country, with 4 different local authorities. So is that, I mean, how is that working out? Are the 4 areas also meshing together, and is that aspect working well?
I genuinely think it is working well. There's a lot of cohesion and collaboration at the ICB level, and I think people are quite generous with sharing what they're doing well. I'm not bashful in saying it. A lot of the issues Luton has led, and I think that's acknowledged within the BLMK system, possibly because it was a bit smaller, a bit more, cohesive, a bit of organisational memory. So again, I emphasise that it's that working really at that neighbourhood level. And it is about relationships, and keeping the resident at the centre of it, at all times. Again, it's not perfect, but I think if we're very clear about what problems we're trying to solve, and do we put some measures that we all agree to see whether or not we're making any difference. And without any shadow of doubt, with the population in Luton, it has to be about targeting and going that in-reach work, which we learnt from COVID. You've got to go into the communities, can't expect them to come to us because they don't. So if we can increase vaccination rates, helping people to seek help if they've got early symptoms, and making those screening opportunities more amenable, convenient. And again, that is some of the work that the public health teams with colleagues that work with the cancer networks have really come forward as the cancer champions. So again, could do better, but I think we're leading the way in some of that.
Okay, You're talking about the pre-diabetes program, talking about how successful that is. Are we promoting that success? Are we telling everyone how good it's been?
We actually are, and because we're all part of this system, the integrated care system, we have everything's happening this week. So we have, I believe it's Friday. It is Friday. We've got our NHS, what we call Q2 checkpoint. So each of the local authorities have got a page. So I'll happily share the page because I think Mark, Jill, Sally, myself are proud at what we're putting for Luton. So, and that is one of those areas that we've highlighted. And that means that we've made the offer to our residents about accessing support to who are higher risk of developing diabetes, and they've taken it. And that's probably what I call a community entity, in the sense that, you know, somebody mentions it and it goes to the neighbour, and then it becomes, this is something good, encourage you to do it. So yeah, and at the end of the day, it has to be like any offer. It's got to be convenient, it's got to be proportionate to what people are prepared to spend time, and the feedback's been rather good.
Excellent, thank you. If that's it, thanks very much, Nikki. Thank you. Okay, next item is the draft work programme, and I think we have been asked by the executive, following on from the healthy advertising report that we considered at the last meeting. We have been asked by the executive to consider how the licensing and planning systems can be used to help with the fight against obesity. So that is something that will be in the forthcoming work programme at some point, if that's okay with members. Okay. And I think the rest of the programme is looking quite. So the next meeting is looking quite full. Is there anything that anyone would like to include, or anything that needs to be brought forward? No, sorry, yes, Councillor Ali.
It's really silly. So the list of potential future items, are we requesting for them to come on the future agenda items, or are we just waiting for when they're ready and then they'd be put in?
It's a mixture of waiting for them to be completed, or waiting for example, for the report on the new mental health bill. So waiting for that to come through. So I guess in the course of time, these will all have their dates confirmed, and they'll come onto the programme. Is there anything in particular you're interested in?
I do remember David Agaby, ex-councillor, asking about the maternity pathways a few meetings ago, and wondering when that report would come. But I'm guessing we're sort of just waiting for Sally to get back to us, I assume.
But yes, okay, we can find out if there's a date in mind for that. Yeah.
And then I saw there's no meetings in March or April due to elections. Is that just anticipating a general election, or February 24th?
I think that's PCC election.
Okay, is that why?
Right.
Okay, makes sense. And I'm also wondering if we could add something to the work programme.
Sure, yeah.
I don't know if this would even be possible, but I know we were talking about diabetes, but I wanted to know about access to diabetes technology, and what we as the ICB are doing here, because I've read a little about postcode lotteries and the different ICBs offering people access to different technology and it affecting their outcomes. I'm wondering if we could get some information on that, whether it has to be presented here, or if we could get some information on it.
I think we just need to home it down. So you may be talking about continuous glucose monitoring. So it may be that. So we just, if we have a discussion about what it is that you homing in on, otherwise it's a huge topic.
Okay.
Okay.
Thank you.
Thank you. Jill, yes.
Yeah, I know we discussed a number of items for social care and they've come forward on the forward plan, just to make the board aware that we're just finalising those dates, because some of those things have to go through various other routes first, and so we just need to map that and make sure we've got the right date for you. So there may be some changes, but not on everything.
Okay, yeah, thank you. That's it. Call the meeting to a close. Thank you, everyone.